Thank you, Ankur sir, for your kind introduction. Now, the topic given to me is the case-based approach to acute pancreatitis and what are the diagnostic issues. I will talk briefly about the issue. I'll start with a case scenario. 8-year-old boy who presented to us with a history of a severe epigastric pain abdomen for last 4 days, which was dull aching pain. It was non-bilious vomit, associated with non-bilious vomiting, and the pain abdomen was getting reduced after vomiting. There was no history of any jaundice, pale stool, no history of NSAID intake, hematemesis, melena, no history of any abdominal distension, gola formation, or borborygmi. There was no history of any trauma. The characteristic of the pain was that the pain was radiating to the back, and it was getting relief from bending forward position. So, usually the differential for epigastric pain abdomen in children is acute pancreatitis, acute cholecystitis or peptic ulcer disease. But with the typical history of pain, which is epigastric, severe dull aching pain, radiate to the back, and which was getting improved on bending forward position. So, our provisional diagnosis is acute pancreatitis. Along with that, we took a certain history for knowing the etiology of the acute pancreatitis. But there was no history of any abdominal trauma, no history of any drug intake. There was no history of any jaundice, biliary colic, or any viral prodrome. There was no history of any headache, blurring of vision, or skin rash, hematuria, which, or no history of any recurrent pancreatitis or pancreatic carcinoma in family. We went ahead and the examination findings in the child was there was tachycardia. The blood pressure was on the higher side at the 90th centile, but not above it. There was mild tachypnea, but the saturation was 97% of room pair. On general examination, no pallor icterus. Per abdominal examination, there was mild epigastric tenderness. While there was no epigastric fullness, Murphy sign was absent, Gray Turner Cullen sign was absent, there was no shifting dullness. Rest of the systemic examination was normal. So we went ahead to investigate the child, and the serum amylase lipase that we sent, it was, as we can see, the very more than 3 times elevated than the upper limit of the normal. We did an ultrasound abdomen which showing bulky pancreas. There was no peripancreatic fluid collection. There is no gallbladder or CVD stone. So now, as we know, this is the diagnostic criteria by definition of pediatric acute pancreatitis, and it is given by International Study Group of Pediatric Pancreatitis in Search for a Cure, that is INSPIRE criteria 2012, and it requires at least 2 out of the 3 criteria should be fulfilled. They are abdominal pain, which is typical pain. They are compatible or suggestive, like the acute onset pain, epigastric, radiated to the back, and get a relief on bending forward position. Along with that, there should be elevation of serum amylase and or lipase activity, which should be at least 3 times greater than the upper limit of normal. And the imaging, cross-sectional imaging, there is characteristic or compatible with acute pancreatitis. So in our child, we had all 3 positive. Our diagnosis was acute pancreatitis. While investigating these pancreatic enzymes, we should keep in mind that that serum lipase, it gets elevated in the serum within 4 to 8 hours of the initial insult. It stays, reaches a plateau and keeps elevated from day 1 to 8, and it remains gradually decreases over day 14. While amylase, it starts getting elevated after 6 to 8, 12 hours of the initial insult, plateaus at 3 to 5 days, and it becomes normal within day 8. So we have to keep in mind this image, because if there can be false negative and false positivity. In mild cases, there may be false negative serum amylase, which can be seen in 10 to 15% of the cases. If early fatal pancreatitis, then we don't, there is no acinar gland, we don't get elevated serum amylase. Or if it is a acute exacerbation of the chronic pancreatitis, so in that case also there will be not much elevation of serum amylase. Hypertriglyceridemia, which is usually a cause of recurrent acute pancreatitis or chronic pancreatitis, they can hamper with the amylase. This is an amylase inhibitor. So in those scenarios, serum amylase will be low, So we have to depend on other modalities like clinical history and imaging. And the late presentation, like after coming after 1 to 2 weeks, in that cases, serum amylase will be normal. There are certain other conditions where there will be a falsely elevated serum amylase, like acute cholecystitis, acute appendicitis, peptic ulcer disease, intestinal infarct, perforated viscous parotitis, salpingitis, and renal failure. A condition called macroamylesemia can also have falsely elevated serum amylase level. Now, serum lipase, as we all know, that its sensitivity is similar to amylase, but it is more specific than serum amylase. False positivity can be seen in renal failure, small bowel obstruction or perforation, and acute other causes of acute abdomen. While we investigate a child of acute pancreatitis, we must also simultaneously investigate to look for the underlying etiology, and so that we can treat those conditions. Like the one of the commonest causes is the biliary causes. So the liver function test, history of jaundice, and on the imaging, the common bile duct dilated or common bile duct stones, they can give rise to pancreatitis. So in our case, it was normal. Elevated serum triglyceride, usually more than 1,000, is known to cause pancreatitis. So we did a fasting lipid profile in this child, which was also normal. Serum calcium level elevated, which is usually seen in associated with hyperparathyroidism or malignant conditions. In that condition also, pancreatitis can occur. In our case, it was normal. Congenital anomalies like colorectal cyst, they are known to cause pancreatitis. But in our case, ultrasound was normal. MRCP, which was done later, it turned out to be normal. Collagen vascular diseases are also known to cause acute pancreatitis. In our case, there is no hypertension, no proteinuria, no history of any arthritis or skin rashes. Another condition like hemolytic uremic syndrome, they can present with pancreatitis. But in our cases, renal function test, peripheral blood smear, hemogram, all were normal. Once we diagnose the case of acute pancreatitis, we have to grade the severity of pancreatitis, and it is by revised Atlanta classification, and it is usually divided by 3 groups: mild, moderately severe, and severe. In the mild case, there is no organ failure. I will show in the next slide what we call defined by the organ failure, and there should be no systemic or local complication. In a case of moderately severe acute pancreatitis, there can be organ failure, but usually it is transient and improves within 48 hours, or there is a local or systemic complication. And the severe acute pancreatitis is where there is persistent organ failure more than 48 hours. For defining the organ failures in acute pancreatitis, we have this modified Marshall scoring, which shows the severity in the respiratory, renal, and cardiovascular dysfunction. In the respiratory system, we check the pulmonary arterial oxygen and FiO2 ratio, and we give them certain scores according to the values. In the renal system, we check the serum creatinine, and cardiovascular system, we check the systolic blood pressure as well as the requirement of inotropes or not. So if the score is more than 2 in any system, that is defined as organ failure. If more than one organ is involved, that is multi-organ failure. So what are these other local complications that was required for defining the moderately severe acute pancreatitis? Usually they are the fluid collection with which is usually acute peripancreatic fluid collection within 4 weeks, pseudocyst, which is more than 4 weeks for the onset of pancreatitis. Acute necrotic collection in the setting of acute necrotizing collection within 4 weeks, it is acute necrotic collection. More than 4 weeks, it is world of necrosis. There, there are certain other complications. They are not like gastric outlet obstruction, coronary necrosis, aneurysm, or say splenic vein thrombosis. They are usually suspected. Usually, the mild acute pancreatitis resolves within 3-4 days. If there is a persistent or there is recurrence of abdominal pain, if there is a secondary increases in serum pancreatic amylase or lipase activity, if there is increasing organ dysfunction or development of clinical signs of sepsis, that is fever and leukocytosis, especially after first week of onset of pancreatitis. The systemic complications are enumerated here, like lungs, heart, circulation, brain, metabolic, coagulation, and kidney. However, they are rare in children. They are separate from organ dysfunction, are usually not seen in children. There are many clinical severity scores. With the help of this clinical severity score, we can predict whether the child is going to have any severe course or mild course. So there are certain clinical scores like Ransom scoring, Apache scoring, BSEP scoring, SIR scoring, Japanese severity score, and harmless acute pancreatitis score. But these all scores, they are studied and validated in adults. In pediatrics, not much scores are available. We have this D12 score and pediatric Japanese severity scores. These are clinical severity score. There are certain radiological severity scores which are done in the basis of cross-sectional imaging, like Balthazar CT severity index, pancreatic size index, extra pancreatic inflammation CT index, and mesenteric edema and peritoneal fluid index. But these radiological severity scores, they have better sensitivity more than and specificity more than 80%. This is the D12 score is used in children. There is two evaluation. One at admission, another is after 48 hours of admission. In that, the age is at admission is it is age less than 7 years, weight less than 23 kilo, admission less WBC more than 18,500 per cubic millimeter, and LDH more than 2,000. 48 hours, we assess the serum calcium level, albumin level, fluid sequestrations, and rise in blood urea nitrogen. If the score is more than 3 criteria are fulfilled, then it predicts a severe course of pancreatitis, and the sensitivity of 70 and specificity of 76%. Now I'll talk briefly about the role of imaging in diagnosing the acute pancreatitis. The findings that are typical of acute pancreatitis in ultrasound, the pancreas is usually diffusely enlarged and hypoechoic. Whether the child has any, it is an acute pancreatitis or any exacerbation of chronic pancreatitis, we can have certain idea, like calcification, atrophic, and duct dilatation. There may be collections and ascites, and biliary system can be evaluated like gallbladder, CVD calculi for knowing the biliary pancreas. However, ultrasound abdomen has its own drawback. In 25 to 30% of cases, we get the reports that the pancreas is not visualized for excessive bowel gas, and it may interfere with the evaluation of CBD and calculi. It is also not very good for assessing the extrapancreatic extension and not useful to certain what is the severity of pancreatitis. Do we require CT in all? Answer is no, especially in acute pancreatitis within first 3 to 5 days. It is not indicated in especially mild pancreatitis, radiation exposure in a concern, in which settings we have to do a CT abdomen. Like there is an ambiguity of clinical syndrome, very small children who are not able to give proper history of the pain or localize the pain abdomen. There is amylase lipogenesis borderline, or ultrasound abdomen reports is doubtful, or the child is have pancreatitis, but even after 72 hours, not showing any signs of improvement, rather worsening, and clinically severe acute pancreatitis. And if usually we should wait for at least 72 hours, because in this scenario, contrast enhanced CT scan may worsen the and cause renal shutdown. Now, the pancreatitis, on the basis of this cross-sectional imaging and course, there is two types. One is the acute interstitial edematous pancreatitis, and another is acute necrotizing pancreatitis. Most commonly is acute interstitial pancreatitis at 80 to 90% of cases, where in the imaging we will see focal or diffuse homogeneous enhancement. While in necrotic, there will be the parenchyma or peripancreatic tissue, they are usually necrosed. Usually the first interstitial nephritis resolves within 1 week, and the course is usually uncomplicated. While the actual necrotizing pancreatitis, usually it takes time to resolve, and usually it is associated with other complications. Here are the certain images. The first image, the arrow marks, it is showing that we can see the pancreas is diffusely enlarged and edematous. In the second side, in the right side, In the star marks, they are showing the necrosed area in the necrosed parenchyma of the pancreas. In the lower image, we can see there is a fluid collections, and the fourth image there is the air foci within the collection, that is indicating there is these collections are infected. This is other two images. First one is the acute interstitial pancreatitis, and the second one is there is peripancreatic fluid collection. I talked previously about the other complications due to pancreatitis, which can be like the splenic artery and splenic vein. They lie very close to the pancreas. So the inflammation, and there can be splenic artery aneurysm. It can present with hemosarcus pancreaticus also, and that give rise to life-threatening bleeding. There can be splenic vein thrombosis, leading rise to collateralization and left-sided or sinistal portal hypertension. Now, there is a CT severity index, that is Balthazar index, and it has certain two things are assessed. One is the tomographic finding, what are the appearance of the pancreas, and other is the proportion of the necrosis of the pancreatic parenchyma. In the grade 0 is the normal parenchyma. Then grade B, there is a enlargement of the pancreas. 3 is the peripancreatic. Grade C, peripancreatic inflammation. Grade D, there is a fluid collection. Grade D, E, that is 4 points. There is a multiple collection, or there is presence of gas within the pancreas. And the necrosis, no necrosis 0 point, 2 points is given for up to 30% of necrosis, 30 to 50% is 4 points, and more than 50% necrosis is 6 points. So if the severity index is 0 to 1, there is usually seen as 0 mortality and morbidity. And if the severity score is 2 to 3, there is 8% of morbidity and 3% of mortality. If the score is more than 6, then the mortality rises up to 16%. But the drawbacks of image CT scan is that it is not good to assess the solid component of the necrosis if there is a necrotic collection, and it is also not good to assess the biliary tracts, especially the lower end of CBD. And the ductal anatomy is not also properly delineated in CT imaging. So in this scenario, there is a role of MRI or MRCP, especially for the assessment in the setting of renal failure in a case of acute pancreatitis, or the presence of solid component with the necrosis, and also the biliary tree, especially the lower end of CBD, it will be better delineated in MRCP. But in the setting of acute inflammation, the anatomy may not be properly delineated. In children, what difficulty we get encountered to get the MRI? MRCP or MRI abdomen requires a lots of breath holding. The children cannot do, or the patients may have respiratory distress. In those situations, it is very difficult, and gadolinium may rarely cause nephrogenic systemic sclerosis. X-ray abdomen or X-ray chest may help in certain situations like the pleural effusion, pulmonary edema, basal atelectasis, pneumonia. Erect septal abdomen can show this colon cut-off signs, perforation, localized ileus, and it can show also localized signs of underlying chronic pancreatitis like calculus or calcification of the parenchyma. Now, once we diagnose that the child has acute pancreatitis, and this is his severity, we also have to know what are the etiology in pediatric acute pancreatitis, because they are much different from the adult. In adults, the majority of pancreatitis is alcoholic and biliary. In children, they are different, slightly different. Like pancreaticobiliary, congenital causes, political cyst, abnormal pancreatobiliary junction, pancreas division, they are common. Acquired like choledocholithiasis, ascariasis are also seen. Infective causes, virus, acute viral hepatitis is also known to cause acute pancreatitis. And parasitic ascariasis is notorious for causing this pancreatitis. Cryptosporidium, especially in patients who are immunocompromised. Then traumatic pancreatitis, which can be observed or can be unobserved. They are one of the commonest causes of acute pancreatitis in children. We should not forget about the metabolic causes like hyperlipidemia, hypercalcemia, because their treatment is also different. Severe hypertriglyceridemia more than 1000, they can cause pancreatitis, and in this situation, only conservative treatment will not help. We may have to treat that hypertriglyceridemia by fasting, insulin infusion, or heparin infusion, and with that help, unless we reduce it to below 500, it will not improve and may even worsen and cause renal failure. Certain systemic causes like vasculitis causes, hemolytic uremic syndrome, henoch purpura, Kawasaki disease, SLE, they are also known to cause pancreatitis. Other causes like post-acute pancreatitis, familial, and a major chunk of our cases can be idiopathic also. Drugs are one of the another group which can cause pancreatitis. And the special groups, they are like analgesics, anticonvulsants like phenytoin, valproate. Certain drugs we very commonly use, like steroids, azathioprine, even sulfasalazine we have seen in our patients causing pancreatitis. Anti-cancer drugs which are commonly used in childhood leukemia, like L-asparagines or cytarabine, they are also known to cause pancreatitis. These are a few series which has looked at the causes of pediatric acute pancreatitis. This study published from our center in 160 children. 52% of them were idiopathic pancreatitis. The other major causes were traumatic pancreatitis and biliary, viral, and drug. In other studies from even Western countries are also showing that the in childhood pancreatitis, idiopathic and traumatic causes are they encapsulate a major chunk of the patients of acute pancreatitis. So the take-home message will be that we must be able to recognize the acute pancreatitis by identify the typical clinical features. We should look for systemic causes in younger children and the other treatable causes like biliary causes or metabolic causes like hypertriglyceridemia, hypercalcemia. In vigilance should be there to identify the complications early and the organ failure early. We have to document definite pancreatitis by enzyme assay and ultrasound. CT scan should be avoided within 72 hours, and the further imaging only in select indications, not in all. Thank you.